Suicide has been a top 10 cause of death for several decades. Unfortunately, it's actually gone up in recent years. Since 1999 through current, the rates have continued to rise to the point where we now have 45,000 approximately suicide deaths in the US every year. California, the overall rate is about 10 per 100,000. In Sacramento, it's higher than that. It's about 14 per 100,000. So we're one of the counties where it's above the state average. And then if you look at some of the surrounding rural counties, it's even higher. Placer, El Dorado, Amador, it's 30 per 100,000. And this fits with national data that shows that the more rural or sort of semi-urban, the higher the rates. California is not by any means the highest state, but we do have these counties where the rate is higher. We ideally don't want anybody to kill themselves, so it's important everywhere, right?
Yeah, right,
yeah.
right.
The rates are particularly high among men because men tend to use more lethal means, like firearms, even though women actually attempt suicide more often. So I mentioned that 10 per 100,000 in California. It's about 18 per 100,000 in men versus about 5 per 100,000 in women. So that really kind of illustrates that gap, which is getting more narrow over time. But middle-aged men and older men continue to be at extremely high risk. That's why the CDC, the Centers for Disease Control and Prevention, funded our study. They wanted us to focus specifically on that high-risk group.
Is there any indication that the internet has played a role? Because that's come of age as that trend has grown.
It's a great question. Most of the data would suggest that it's more related to other societal factors, although that could be one. In particular, the downturn in the economy over the last couple of decades and the gap between the super wealthy and the rest of the country. People are feeling more and more strained financially, even though obviously there's a lot of changes in the way that with both men and women in the workforce now, it still has disproportionately seemed to hit men. And also I think ties into the idea of men's traditional gender roles as the head of household and feeling sort of responsible financially. And when things get tough, that puts a strain on relationships and things kind of go south from there. There's other factors as well, including the distance between people with technology, but that sort of affects everybody. The issue with men seems to be related to finances and traditional roles.
You mentioned the CDC is funding your study. Talk to me about your study. First, let's sort of give it a timeline. When did this first come about? What's your role in it?
We were funded in 2015, so it's a 4-year study. We're now just finishing the randomized trial of the intervention that we developed, which is the study to see if this intervention is actually effective. We developed our approach, and it's called Men and Providers Preventing Suicide, or MAPS. Specifically to target prevention of suicide in the primary care office setting. And the reason we did that is really no other studies had focused on that setting, and yet about half of all people who do end up killing themselves have seen a primary care doctor within the month before they do that. And unfortunately, it hardly ever comes up in those encounters, partly because of stigma and just the perception that maybe the primary care setting isn't the right place. But that's totally not the case. I mean, primary care docs, we receive lots of medical training around mental health issues, and we're really well equipped to deal with it. But there's a lot of other issues going on, and if the patient doesn't sort of send a cue that they're having issues, it may not come up. So the program we developed, it's an interactive computer program that they look at on a little touchscreen device that it encourages them, if they do endorse that they're having suicide thoughts, to talk about it with the doctor right in that visit. And it gives them some motivational videos and text to sort of encourage them to do that, make sure they know it's a safe place and that the provider is qualified to deal with it. It includes some videos that actually role model men of different races and ethnicities in that middle-aged group talking to a doctor about suicide, because a lot of research shows that men sometimes lack the words to talk about medical issues in general, but mental health issues for sure. So it kind of gives them a chance to see how it's done. It's also designed to resonate with men in other ways. Messages that tell men to ask for help tend not to go over very well. Research has shown that they respond better to messages that play to things like, this is a good way to take charge of your health. This is a good way to show that your commitment to your family and your loved ones and be there for them. So the messages are really framed more in that way rather than saying you need help. That's like the old thing about men asking for directions, which is kind of my favorite way of sort of explaining that. They don't like to do that, but if you give them a map, they may be able to work it out.
That's interesting. Yeah, it's about reframing it in a way that sort of empowers them to take charge of their health and not see it as a weakness, but as a strength.
And to be there for the people that depend on them, which is, again, one of the reasons why the rates are going up. They feel like they're sort of failing their loved ones and the people that depend on them when they're having financial issues or other problems.
Another concern men face is boy, if I bring it up, am I going to be hospitalized? Then I really won't be able to be there for my family.
That's exactly true. And really the amount of times that would have to happen in a primary care office are really quite small. There are cases where if the person is viewed or assessed to be an immediate danger to themselves, that would be recommended. But most of the time with good, close outpatient follow-up, the way that we actually integrate into our study, it's not necessary. And to my knowledge, we haven't had to have a single person in our study hospitalized, actually, even though they have all had recent active thoughts of suicide.
What would be a red flag to say this person probably needs to be hospitalized compared to this person just sharing they've had suicidal thoughts? We can help them without hospitalizing them.
It's more about things like, do they have an active sort of plan to do it? Are they saying, I really don't think I can stop myself? Particularly if they're saying, I feel like I'm going to do it, right away. If they're able to articulate that they have the means at their disposal and they've thought through how they would do it, those are very concerning. And if they don't have supportive resources, if they live alone, if they, there's all kinds of access to guns and other things, and they're saying this is how I'm going to do it, those are cases where it may be safer to at least temporarily put a hold on them and have them admitted. But it's more common to see that in an acute care, like emergency room setting. In the office, we're trying to intervene. In most cases, it's much earlier in the sequence where they're starting to feel this way, haven't told anybody in general, but it hasn't gotten to the point where they're sort of unable to control those thoughts.
And it sounds like a lot of that exploration has to do with doctors asking the right follow-up questions.
Correct. Yeah, and there's a piece of our study, it's given to all the doctors in the study to make sure that they are kind of adept at asking those questions. It's a little video module they can look at, and it talks about doing it in a compassionate way too, because that's the other thing our patients told us in this pre-study, is that sometimes when the doctor starts asking questions about suicide, they kind of forget their compassion, because they're a little bit nervous too, and they kind of immediately launch into, do you feel safe? Do you have guns? And they forget to sort of weave those questions in with more empathic responses like, I'm sorry that you feel that way. We wanted to make sure that we gave the docs that sort of training so that we don't create a problem where the patient then feels less comfortable rather than more comfortable.
The study itself, what has that entailed?
So it's a randomized controlled trial. That means that when a patient enrolls, they are randomly assigned to one of two interventions. One is the MAPS, or Men and Providers Preventing Suicide program, which I mentioned, a touchscreen program. The other is a control where they get very brief information about suicide and encouragement to talk to a doctor, but without all the videos and other motivational material. Because if we're going to convince practices out there to adopt this, we need to prove that what we've come up with, although it sounds like it would be better, is actually better. It may be enough just to encourage men right before they see the doctor to talk about it, and that might be enough, in which case maybe we don't need all the fancy videos. My gut feeling is that they are going to make a difference, but that's what the study is designed to figure out. And we're looking primarily at the rates of how often men talk about suicide thoughts in that visit. We do post-visit questionnaires of them and the doctor, and also then how many of them end up accepting the follow-up care that we have integrated into the study. We can't force them to take it unless they are actively a danger to themselves, in which case that can be done forcibly, very rare. But our gut is that people that look at this more refined program with lots of motivational videos will be more likely to accept that follow-up treatment, because it makes sense to them. It's been sort of contextualized. The videos talk about why it's so important, what the care entails, like who are the team members that will provide the treatment, whereas just the brief control information, it doesn't have time to really get into that. We've finished actually recruiting, and we're following the last few men through their 3-month follow-up period. It ended up being 50 total. It was a small study, but we think we can see a difference in their 3-month follow-up. There's a suicide scale that basically rates the amount of symptoms you're having, whether you're having suicide thoughts, and if so, how bad they are, whether you've thought specifically about how you're going to do it. That's a measure that we administer, and we look at the 3-month score, and we expect we'll be able to see that the active arm, the MAPS arm, would have a lower score, which is a good thing. We don't have enough power to show a big, statistically significant difference in actual suicide attempts, but we'll look at that for sure. Hopefully with 50 patients, we won't see a lot of suicide deaths, if any, and that's good.
With the size, it's sort of a proof of concept.
Correct. We wanted to recruit a lot more. What we found is that the stigma around suicide is even stronger than we expected. We know that it's a big issue in society. We know from data, national data, that there's a lot of men out there that are having these thoughts. So we would expect a lot bigger study sample, but many men said no, and we had some who initially said no when we called them to see if they, we did phone screening for this study to see if they would be eligible. And we had quite a few who told us no initially, and then like the very next day would call back to the study line and say, actually I am having these thoughts and I didn't feel comfortable saying it, but I've been thinking about it overnight and I need help, you know, or I'd really like to get this under control. And that is remarkable. I've been doing research for 20 years and I've never had patients call back, you know, the next day. So I think it speaks to how hard it is for them to sort of get over that hurdle of telling somebody, particularly a stranger, you know. But it is encouraging that some of them do that. But I think if we could work at a societal level to really change the dialogue about suicide, and the way I like to put it is, I think we're with suicide where we were with depression about 30 or 40 years ago. I think we've done a lot as a society to destigmatize depression. People now know it's a medical thing, you know, there's treatment for it. Not so much with suicide, unfortunately. It's a whole other category, and I think we have a lot of work to do as a society to not normalize it, but to normalize the idea that lots of people feel this. There's treatment. It's nothing, you know, to be ashamed of. Even a lot of the men who signed up for the study would spend a lot of time before committing, asking questions like, well, will my employer be able to find out? Who will have this information? Will it go on my regular medical record? Stuff that we don't hear so much about depression anymore. But that's encouraging. That means that it can change over time.
That's a really good point. Yeah, if it can change with the trajectory of how we see depression, then certainly suicide can be the same.
Right.
Have you been able to see preliminary conclusions you can draw from this?
It's a great question. We don't peek at the data. That's called peeking, and it's interesting. Like, it's sort of highly discouraged because what can happen is if you look at the data as an investigator, some people might be tempted to actually sort of change what they're doing midstream. And so we don't do that. But the good news is we will be able to look legitimately in about a month because we're done with all the recruitment and we're doing those last few follow-ups. So at that point, the statistician will look at the data and we should be able to do the analyses pretty quickly. We've had lots of anecdotal, really good positive feedback from the participants. So we've had men write, you know, basically a testimonial letter, you know, unsolicited, saying things like, this changed my life, and, you know, I was very skeptical at first and worried. And so, I mean, I think that we've seen benefit for sure. The big question in my mind is whether the more elaborate intervention is better than the simpler, just ask about it. And that's really what the trial analysis will show us. But I think the idea of intervening in primary care definitely has value. It's just, right now it's a hard lift because a lot of men who could benefit are just not ready to say it, I think.
I like the fact, I think it's important to point out that the trial, or the control group,
they're still getting benefit, yeah.
Right, exactly. You're not just saying, okay, you identified yourself as someone with suicidal thoughts, like, well, we're not going to talk about that with you, and then
we still offer them the same treatment and everything.
Sure. It's just the heightened with the videos and the program.
And we think more will accept it, yeah. And that'll be a really interesting analysis. Do we get more who saw that MAPS program who actually agree, yeah, I need the treatment, you know?
So let's talk now about, you know, implementation and scale. So let's say the results come back and you say, wow, from this, you know, albeit small study, but we are seeing enough results to tell us this MAP program is making a difference. What is next, and what would that look like in the actual doctor's office, in the waiting room, beforehand? Yeah. It's
designed to be used in the 10-15 minutes that you would normally wait for a doctor. That's the kind of the national average that people wait for a primary care doc. A practice medical assistant, for example, could give it to the patient literally in a waiting area or a quiet room if they would prefer, and they would work through it on a little touchscreen device, just like we're doing. It asks them questions and then gives them, the feedback I didn't mention earlier is actually tailored to their specific answers as well. So a man who says that they're actively thinking of killing themselves and has a plan gets a slightly more forceful message to talk about it than somebody who's just sort of thinking vaguely about it. And so I think it's pretty quickly scalable. The big thing would be making sure that the practices feel like they have appropriate follow-up treatment in place. Not everybody has the type of care we have available, which is called collaborative care, where there's either a psychologist or a licensed marriage and family therapist who then does close follow-up of the person by telephone under collaboration with the primary care doc and a supervising psychiatrist. We have that as part of our practice. If you just had the traditional system where it's just a doc and they have to somehow do follow-up on that patient, those practices might have to get that other type of follow-up in place before they could do it safely. But there's lots of places that could do it right off the bat, and we're not planning on charging for the program. If it's effective, we'd be happy to just disseminate it. They would just have to come up with their own devices, basically, which are, of course, nowadays getting cheaper and cheaper.
In the study, they're iPads.
Correct.
And sort of touchscreen program they go through. Would this be given to any man who falls into that category, comes in for his checkup?
Yes, it could literally be just given, or a practice could decide to do it. You'd need to develop a slightly different version of the program, but since suicide is a big deal in all adults, and teenagers for that matter, I could also foresee developing different variants of this program that would be targeted to different age groups. This group, it's just huge. It's fourth most common cause of death in most of the recent studies. It's above diabetes, chronic liver disease, chronic lung disease. The only things that are higher are like cancer and cardiovascular disease and accidents. It's a huge public health issue that I don't think people really fully get exactly how prominent it is,
And your study is 35 to 74, but what's the age group for the highest risk?
Among adults, full-grown adults, it's that 35 to 64 group where it's the fourth most common cause. Teenagers also have very high risk, but that's a whole other category. And there you do run into things like social media and sort of copycat phenomena and feeling ostracized from your peer group, that kind of thing.
And not to mention what hormones are doing to your emotional stasis, at that time. And so, for example, my partner, he's 31 years old. So let's say he turns 35. He walks in for a checkup at UC Davis Health. He could be given, hey, you're just here for a checkup, and he could be given a device and just go through this. And
he could. And we've developed similar programs for completely other medical issues. Obviously, like we had one that was sort of similar for motivating people to go through colon cancer screening. You could literally have a menu of these programs, and also we haven't ever tested this yet, but let people sort of self-select, the topic that's of interest to them. So a man might come in and they don't have to tell anybody, but they might look at this menu of options and say, well, yeah, I've kind of been feeling this way. Maybe I should look at this program. Or the doctor could sort of push it their way if during a visit it comes up, they could actually even have them look at it after the visit. There's a lot of different ways you could do it, but we're looking at it as a pre-visit sort of what's called activation tool, getting that patient to get it on the visit agenda with the doc so that they can actually do something about it.
Kind of like a primer, getting someone in that right mindset.
Right.
Yeah. Did this become a passion for you because you had some personal experience with suicide?
It's a common question. I have not had, other than very early on, I had just an acquaintance in my early adulthood who did kill themselves, but no close friends or family members. I have not had thoughts myself, but it is a passion in the sense that I've been doing family medicine for 30 years, and I see how mental health issues are like a part of almost every single encounter in some way, even if it's just sort of helping people cope with day-to-day stresses. But a huge proportion of visits in family medicine have some mental health issue. We still have a long way to go with improving the quality of care. And I think if you make an impact on mental health, you can really make a huge impact just on people's health in general, because it affects their productivity, their relationships. It's one of the big factors I think that we don't talk about that's driving the opioid epidemic, where the drugs themselves get a lot of blame, but you have to stop and think, why is it that if you give somebody this pill, many of them get hooked? It's partly genetics, but there's other factors. People are sort of self-medicating things that they're not always talking to the doctor about. Anxiousness, depression, feeling empty, those kinds of things. And I feel like, if we as doctors are all over things like liver disease and chronic lung disease, and yet those actually cause fewer deaths than suicide, it's like, why are we not? This should be like a huge part of our training. And frankly, it's not. I mean, we do get some, but I would say proportionally, doctors don't get nearly as much on that as they do some of these other things, which, not to downplay any of them, they're all important, but we should have this up on the top of the list as well.
So important to emphasize that while this study is focusing on men within a certain age group, it is proof of concept for this program that could be expanded to other age groups.
With
women.
Modifications, yeah.
Sure. I know the videos show, men of different racial backgrounds, but is there a certain, are white men at higher risk than, I remember hearing that in college.
It's a great question. No, in general, it is interesting. It's one of the few things where there's more of a reverse disparity, where it tends to be white, both men and women are at higher risk overall than racial ethnic minorities. It really depends, though, a little bit on the region and the age group. But as we know, in general, there's a huge gap in terms of income and privilege in our country where white folks are at an advantage. But this is a case where when they lose that advantage, it can have very, very devastating impacts on mental health.
Just the concept of there's farther to fall, when your expectations are here as someone with historical privilege in a country. Also, there's an element of cultural isolation,
yes. Less of a collective culture and a supportive culture,
yeah,
right?
For sure. Well, thank you so much for coming in.
Pleasure.
Such
Thanks.
important work.
Great
I really
questions.
appreciate you.
Yeah.
Yeah.